I start showing this graphic that shows change in the number of deaths per year worldwide between 2000 and 2016. The numbers are millions. And below zero, we see the diseases that are decreasing over the time. And above zero, we see the diseases that are increasing over the time. And among them, we see the both diseases that we are going to focus in this work, that are cancer and diabetes. So cancer causes 9 million deaths every year, while diabetes causes around 1.6 million deaths every year. Among the cancers, colorectal cancer is the third one with new diagnosis every year, and is the second causes of death. And the colorectal cancer, or CCR, is on the rise. In 2040, we are going to have 3.1 million people carrying colon cancer, and China, United States, and Brazil are going to be the most impacted countries. Diabetes is also on the rise. It grows 5 times in 40 years, and 1 in 2 adults with diabetes is undiagnosed. It raises mainly among kids and teenagers, and mainly during the COVID years. We have 2 types of diabetes, diabetes 1 and 2. What they have in common is the high glucose levels in the blood that we call hyperglycemia. There are a lot of evidences showing an increase in cancer among diabetes patients, and recently hyperglycemia was considered a risk factor that links diabetes and cancer progression. So how does glucose impact cancer cells? Among the metabolic changes exhibited by tumor cells is an increase in glucose uptake. Tumor cells are highly dependent on glucose. This property has been of great value for the diagnosis of cancer. When a patient receives a radioactive glucose, cells that have increased glucose uptake can be visualized by X-ray. Cells under Barbour effect produce energy fermenting glucose to lactate, despite the presence of oxygen. One advantage of Barbour effect is that the glycolytic intermediates through several biosynthetic pathways that are essential for duplication of biomass during cellular proliferation. After cellular uptake, glucose can be shunted to the pentose phosphate pathways. That is important for the biosynthesis of nucleic acids, which are important for cells that are in divisions. Cancer cells overexpress the rate-limiting enzyme of the hexosamine biosynthetic pathway. The glutamine fructose 6-phosphate amidinotransferase GFAT converts fructose 6-phosphate to glutamine 6-phosphate, have glutamine as nitrogen donor. Glutamine 6-phosphate is further acetylated and activated, generating UDP-GlcNAc. UDP-GlcNAc is then substrate for most of the glycosylations that we know, and the substrate for the intracellular glycosylation, O-GlcNAcylation. So the O-GlcNAc transferase will add glucanac to the serine and threonine residues over 2,000 intracellular proteins, so modulating their half-time activity, interaction, and the cellular localization, transcriptional activity, and interaction with other proteins. O-GlcNAcylation is altered in most of the cancers and is proposed as a prognostic factor in prostate cancer. So glucose is also substrate for the biosynthesis of all monosaccharides expressed on the cell surface, forming the glycocalyx as the the one that we show here from endothelial cells. So seeing this high glycocalyx is easy to understand that the glycans mediate a plethora of events in cell physiology, from host-parasite interactions, immunoregulation, cell growth, cell death, metastasis, interaction with cellular matrix, cell-to-cell adhesion, and tumor cells express aberrant glycoconjugates. So we can imagine that this aberrant glycosylation changes all the biological events that we know. Therefore, our hypothesis is that increased flux of glucose entering the hexosamine biosynthetic pathway contributes for the aberrant glycosylation, which in turn impact tumor progression. To test our hypothesis, we used epithelial cells, both under normoglycemia, that was 5 millimolar glucose, hyperglycemia, 25 millimolar glucose, and osmoglycemia using 20 millimolar of mannitol. High glucose changes cell morphology, so cells growth under hyperglycemia become more elongated and presented increased migration when compared with normoglycemia. Hyperglycemia induced aberrant glycosylation, as we can see by flow cytometry using lectins. Among them, we can see here an increasing of alpha-2,6 linked sialic acid and alpha-2,3 linked sialic acid, together with a decrease of beta-gal epitopes. An analysis of LC-MS of the N-linked glycans showed that cells grow in hyperglycemia presented a higher abundance of total N-glycans, and they were differentially expressed among the hyperglycemic growth cells and the cells growth in normoglycemia. Among the differentially expressed glycans, we found a lot of pulse-mannose glycans, high-mannose, and hybrid glycans expressing sialic acid or presenting both sialic acid and corpusculation. And we could find one hybrid glycans expressing sialic acid and corpusculation as differentially only expressed by cells growth in hyperglycemia. But we wanted to know if the HBP, the hexosamine biosynthetic pathway, was involved in the observed alterations in the glycosylation. So we downregulated the enzyme GFAT. And here we can see that the downregulation of the enzyme was around 70%. And when we analyzed the cells by flow cytometry using the array of lectins, we could see that all lectins decrease after the downregulation of the enzyme, as I destack here, for example, the decrease in the binding to 2,6 sialic acid, 2,3 sialic acid, and the increase in the binding of the beta-galactose epitopes. So we can say that hyperglycemia changed the glycosylation and that the HBP was involved in these changes. And in vivo, does hyperglycemia can change the glycosylation and the cancer progression in vivo? In vivo, we destroy beta-pancreatic cells with streptozotocin injection in black 6 mice and injected colon cancer cells, mice colon cancer cells, in the flank of these animals and follow the growth of the tumors. Tumors from the hyperglycemic mice present an exacerbated grow when compared with the euglycemic mice in size and weight. Thus, the hexosamine biosynthetic pathways is involved in the growth of these tumors under hyperglycemia. To answer that, we injected the cells that had the GFAT downregulated in the hyperglycemic mice, and we see that the cells grow much less than the scrambled cells. They grow less, and here we see a picture of the scrambled cells, the downregulated GFAT cells, and the weight. So we can say that hyperglycemia increases tumor growth in vivo, and that GFAT is involved in this growth. Okay, and what about the other cells present in the tumor? The tumor microenvironment presents non-tumoral cells as macrophages, epithelial cells, endothelial cells that would be affected by the hyperglycemia. So we wanted to see if the high glucose could impact in the anti-tumoral effect of these cells. We then analyzed the tumor infiltrating cells, and the most remarkable change that was observed was in the macrophage polarization. So we can say that we have between two types of macrophages, the M1-like macrophages and M2-like macrophages. The M1 express no synthesis that uses arginine to produce nitric oxide, and expresses pro-inflammatory cytokines. So it has pro-inflammatory activity, performs phagocytosis, and has tumor suppressor activity. And express molecules that can be markers of this kind of macrophages as CD80, CD86, and MHC2. They express toll-like 2 receptors and toll-like 4 receptors, while M2 macrophages express arginases that use the arginine to produce polyamines. They produce anti-inflammatory cytokines, and therefore they have immunosuppressant activity. They perform angiogenesis, tissue repair, and they are pro-tumor. They express on their surface that can be markers the molecules CD200 and CD163. So here we can see the cytometry of the macrophages that were infiltrated in the tumor. Here we see the marker CG206, and here the marker MHC2. So M2 and M1 markers. The macrophages from the normoglycemic mice, we can see that express more M1 marker than M2. Now see how are the macrophages from the hyperglycemic tumors. They express much more CD206, therefore they are more M2-like macrophages. This was interesting, and we asked if it was really the hyperglycemia that was changing this polarization, and if the hexosamine biosynthetic pathway could be involved in these changes. So we performed an in vitro experiment. So we isolate bone marrow cells, differentiate them to macrophages, and after we polarize them using gamma interferon, LPS for M1, and IL4 for M2. So here we can see the markers of M1 and M2 macrophages. And we see that the macrophages that were cultured in hyperglycemia, they express more arginase than the ones that were grown under normoglycemia. So they are more M2, while the the macrophages under normal glycemia, they express more no synthase. And the macrophages under hyperglycemia, they express more CD206 and less CD86. So remember, so they are more M2-like macrophages. Thus, the flow through the hexosamine biosynthetic pathways change under hyperglycemia. So we measure the amount of UDP-glucinac in these macrophages, and we see that, yes, hyperglycemia increases UDP-glucinac levels in these cells, mainly in M2 macrophages. And here, the O-GlcNAcylation of these macrophages, we see that we have an increase in the O-GlcNAcylation that is seen by the antibody against proteins that are O-GlcNAcylated. We see that the M2-like macrophages have more O-GlcNAcylated proteins. So, hyperglycemia increases the flow through the hexosamine biosynthetic pathways and induces the polarization of macrophages to M2 phenotype. But we wanted to know if the hexosamine biosynthetic pathways is involved in this polarization. If we inhibit this pathway, we could change this polarization. Therefore, we differentiated the bone marrow cells and polarizate the macrophages to M1 and M2 phenotypes in the presence of inhibitors of the pathway. So we used an inhibitor of the GFAT, DOM, that will inhibit all the pathway and the O-GlcNAcylation. We use the TMAD-G that would inhibit OGA, increasing the O-GlcNAcylation, and we inhibited the OGT, decreasing the O-GlcNAcylation. When we inhibit the GFAT, what we can see. So here it is, we cultivated the macrophages in hyperglycemia and normal glycemia, and we see the markers for M1 phenotype and M2 phenotype. In hyperglycemia, we see an increase of CD206, that is M2 phenotype. And then when we inhibit GFAT, we see a decrease in this marker, and an increase in the markers from M1 phenotype. Therefore, we can say that inhibiting this pathway, we polarizate the macrophages to M1 phenotype. And when we inhibit the OGA, so inhibit the hydrolysis of O-GlcNAcylation, increases the glycosylation. What we see? We see here one increase in the CD206 marker and a decrease in the marker for M1 phenotype. Therefore, we can say that if we increase the O-GlcNAcylation, we increase the M2 phenotype. And the other side, if we inhibit the OGT, decreasing the O-GlcNAcylation, we see the decrease in the FM2 marker CD206 and one increase in the marker, the M1 marker CD86. Therefore, we can see that if we decrease the O-GlcNAcylation, we induce M1 phenotype. So if our data are right, colorectal tumors from patients with hyperglycemia or diabetic patients would have more M2 macrophages. And so we had the samples and we analyzed the presence of M2 macrophages using the CD206 antibody that is in red here. And we see that in patients that had hyperglycemia, we can see more red cells, more M2 macrophages than we see in normal glycemic patients. So, from our results, we can suggest that increase in the O-GlcNAcylation induces the polarization to the M2-like phenotype that are pro-tumoral macrophages. Together, our results suggest that the high glucose induces increases in UDP-glucNAc and O-GlcNAcylation levels, resulting in an M2 or pro-tumoral phenotype. And an inhibition of O-GlcNAcylation leads to a M1 that are anti-tumoral macrophages. These results raise another question. Can the inhibition of O-GlcNAcylation reprogram the tumor-associated macrophages in vivo to an anti-tumoral phenotype that would then decreases the tumor size? To answer this question, we injected the GFAT inhibitor, DOM, in high P in the hyperglycemic mice and followed the tumor bone. And we see here that after 2 injections, we can see decreases in the tumor growth. And after the first injection, when we look for the polarization of the macrophages, we see that inhibition of GFAT, so using DOM, decreases, here we are seeing the CD206, so M2 phenotype, we see that the DOM decreases the CD206 marker. And when we inject the OGA inhibitor, increase the O-GlcNAcylation, we see an increase in this marker. So yes, inhibiting the O-GlcNAcylation, we can reprogram the macrophages to a M1 phenotype that decreases the tumor size. So here we can make a conclusion using this image that represents the chocolate factory from Willy Wonka and the chocolate factory. Glucose rivers are here the chocolate rivers. So the glucose rivers feed the pentose phosphate pathway that is involved in DNA biosynthesis and cell division. It feeds glycolysis that is involved in energy production and in HBP that is involved in cell glycosylation. Increased flow through HBP generates aberrant glycosylation, leading to tumor progression. Thus, our work suggests that GFAT and OGT inhibition are good targets for drug design and that HBP might be the link between diabetes and cancer. To finish, I want to thank to my co-worker, Wagner Barbosa Dias, to the students involved in this work, Andrea Vasconcelos, Adora Oliveira, Romulo Santos, Natália Montuano, Hector Ponte, to Frederico Alisson, my co-worker, nowadays to the funding agencies, FAPERD, CNPq, CAPES, and for Leonardo Teixeira e Júlio Freitas, do Instituto Nacional do Câncer, ao professor Heinz Laubry from the University Hospital of Basel, Switzerland, where Natalia made most of the experiments shown here, and Cesar Bastos from the Hospital Marcílio Dias. And thank to you all.